Hi guys, we will get started in just a few minutes. I've been having major Wi-Fi issues all day, so I'm on a hotspot on my phone. But I'm just trying to pull some stuff up so we can get this going and do this. So just give me a few here. Okay. Okay, perfect. Okay. Alrighty. Just pulling up some stuff here. Can you guys hear me okay?
Yes.
Yeah.
Okay, good. All right. All right. So what I have planned for today for the review is kind of like a randomizer. So we can start with one of the systems, and then I have this wheel that will spin and it'll land on something, and we'll talk about it, and I'll ask questions, kind of see where you guys all are with those. So let's do, I don't know, what do you want to do first? Obesity, diabetes, or GU?
We can do obesity.
All right, we will start with obesity then. Let me pull up that wheel and we'll start there. Let's see how this works. I wanted to try something new. Had a hard time with everything. All right, so here's the wheel. Good to go. Give it a little spinny spin. All right, so education. Let's talk about education. Oh, stop it. Sorry, see, I don't even know what I'm doing. Education with obesity. Sorry, I don't know how I can get those sounds to stop. So what education would need to be provided to our obese patients?
Would you want to talk to them about lifestyle changes?
I'm sorry, could you repeat that?
Would you want to talk to them about lifestyle changes?
Absolutely. So what would that entail?
Diet modification.
Okay, what else?
Exercise?
All right, what about exercise?
Just like putting it into your daily routine would be best, and it doesn't have to be like scary, like hard stuff. It can be like just going on a walk.
Okay, start low and slow, right? Like take your time, work things out. Okay, what other education? So we've got some lifestyle modifications. What would you, your obese patient, what would you want them to know? How does obesity affect other body systems?
It can cause like diabetes and high blood pressure, things of that nature.
Okay, yeah, it is definitely difficult on all the different systems. So remember in your slides, and I think in your textbook, it talks about every system that's affected by this. So we see it in the cardiac system with hypertension, with heart failure, high cholesterol. Then we have things, the damage that it can do to the musculoskeletal system, the chronic low back pain, the joint pain, the inability to move, how it impacts the respiratory system. How does obesity impact the respiratory system?
Makes it harder for them to breathe
Okay, and why is that?
because the pressure it's putting on the chest. All the
Absolutely.
extra weight.
Yeah, their bigger surface area in the abdomen makes it harder for the abdomen, the lungs to, and the diaphragm to open up and get air exchanged. So most definitely, they're at high risk for sleep apnea. Everything will kind of collapse when they're sleeping, so that's very dangerous. So these are things we'd want to educate them on. What about, well, let's see here. Oh, we just had something in the chat. Let me open that up. Yep, there we go. Sorry, Carolyn. I'm trying to think. Let me see my slides here. So that'll take care of that. Anything else I want to hit on? Okay, nope. We'll carry on with the conversation. The other one that came up accidentally were medications. So let's discuss obesity medications. What's an important thing to know about the obesity medications?
Sorry, you're breaking up.
Oh, I'm sorry. What's important to know about the medications?
If they're actually taking them.
Okay.
Are you talking about like things like metformin for diabetes? Like, are you asking about things like that?
Well, we have a couple of meds that can be used for obesity.
Would
There
that
were
be
three
like the anti-lipidemics or?
There
Are you-
was the, ooh, what was that?
I was just gonna say, are you talking about the Orlistat, lorcaserin, and Phentermine? I can't remember. Yeah. Phentermine?
Yeah, so we have those three meds. So the Orlistat, that's like our ally, that's over the counter. So what would we need to know about that medication?
They'll have oily discharge and low bile.
They will be leaking poop out of their butthole. Okay, they call it oily discharge, but it is like a large amount of stool leakage. If they consume fats, so Orlistat is going to block the absorption of fat. So if we ingest it, then we would get that kind of that side effect of it. So it's a kind of like a deterrent for those taking it not to do that. So we have to be careful with the diet with that medication to make sure that they're following that. With any medication, with any weight loss medication, what would be an important teaching to be done with that then? Any of them?
That it doesn't replace the diet.
100%. This is taken in addition to diet and exercise. So the phentermine pyramid, that's another combination med that we can use. This one we have a lot of anticholinergic side effects with. So the dry mouth, the irritation, constipation. And then this one will just help us feel full. So it works on more of a neurological standpoint. Diet, exercise, plenty of fluids to help with this. Anything else that you'd want to know about medications? You feel good with those? Okay. All right, so let's go ahead. Oh, spin the wheel one more time. What do we got here? Music is a trip. Oh, we had that one already. Let me turn. I thought the music was going to be fun, but it's actually kind of bothering me. So no sound, unless you guys really liked it. I just said don't use it. Okay. This isn't working. All right. So nursing interventions. So with our care of the obese patients, we're going to promote diet and exercise, right? What are some other things that we're going to be doing or need to be aware of?
Maybe like pressure sores.
Okay, 100%. So they have specialized beds and chairs to help with weight distribution, to help prevent those from happening.
Like falls risk.
Okay, why do you think they're at risk for falls?
Just because it's difficult for them to like move.
Potentially, that will definitely be decided on the size of the patient, because if we think about the BMI and obesity as a whole, some people will be obese, but they can still move and they still function. So our very like 500-pound patients may have difficulty with movement, but still some of our higher BMI patients are out there working out and doing stuff every day. So, but definitely something that we need to consider. What about medications, just medications in general, not even obesity medications. What are some things that we would need to consider?
Maybe they need like a higher dose because of their weight.
Yep, some medications are weight-based, so we would need to make sure that we have an accurate weight on file. What's the best way to weigh someone? Best way to weigh someone?
With this little
Like,
closes.
I'll go for it.
Well, you'd want to do it with like the as little clothes as possible and make sure you're weighing them like the same time of day, same scale.
Mm-hmm. Preferably standing if they're able to, but if they're not, then we are going to use, like a bed weight, but zeroed out before the patient gets in. Okay. Anything else that you would want to do? What about their skin?
Wouldn't we want to keep it dry? That way we're not causing like yeast infections or anything in between folds.
Yep. And like I mentioned in my group too, that stuff can happen anywhere. It doesn't matter how big you are. If you have, boobs or a butt, it gets sweaty and we need to keep it clean and dry. So, but we definitely do see that with some of our more voluptuous patients, where there's more folds for things to hide. So 100%. All right. Let's spin that wheel again. What do we got? I want to jump into, I think we'll do, let's talk about the bariatric surgeries. So what are the different kinds of surgeries We had 4 main ones that we talked about in class.
Restrictive and then restrictive and malabsorbent.
Okay, so we had those 2 groups, and then each of them had 2 different kinds of procedures within those groups. So let's talk about the 2 restrictive. What were the 2 restrictive guys? I can't talk. It's been a long day.
The banding and the sleeve.
Okay, so the gastric banding did what?
Lowers the volume of the stomach.
Okay, specifically how? What do we do to the stomach with the banding?
Isn't it like almost like a device that clamps part of the stomach?
Yep. So it's literally like, it almost looks like a zip tie that goes around a portion of the stomach to restrict the size of it, and will decrease the volume so you don't eat as much. And then it will only have a pouch about 10 to 15 mLs that food will fit into at any given time. He has done lost his mind. Okay, then what was the other restrictive procedure?
The sleeve.
The sleeve gastrectomy. Okay, and what happens with that procedure?
They cut along the stomach, right? They suture it up.
Yep, so they're going to remove a portion of the stomach, and the portion that they're removing is the part that secretes ghrelin, which is the hunger hormone. So by not having that there anymore, it will reduce the urge to eat. The stomach is smaller in size, but it's not as sorry. It's not as restrictive. It is, I can't say it's as restrictive, but there's a little bit more surface area in the stomach, but that hormone being removed really aids with the weight loss. And people that have had these have had great success with them as well. Okay, so then what were our 2 restrictive and malabsorptive surgeries?
Is it the gastric bypass?
Okay. So that was the Roux-en-Y gastric bypass. And what was the other one?
It's something with like duodenal something.
It has a lot of words. The biliopancreatic diversion with a duodenal switch. So both of these will require lifelong mineral supplementation. They both are restrictive, and they both are going to basically rewire the GI tract. So with the Roux-en-Y, it will decrease the volume of the stomach, and then it's going to take part of the intestines and attach it. It's going to bypass, hence its name, the duodenum and some of the jejunum. And the new fusion point we have attached to the upper part of the stomach, it creates an anastomosis, which is like a fusion of things. So with both of these surgeries, what potential complications are there?
Like malabsorption of nutrients.
Okay, 100%.
Infection and bleeding.
And
Would-
because we created this new point, what was that called? Does
Is
anybody
it the
remember?
anastomotic leak?
Yep. So with both of those, we have to be really concerned about the leaking of contents. So we've been talking a lot about peritonitis like for the past 3 weeks. And if we have leakage of stool into the peritoneal cavity, that's how peritonitis, one of the ways peritonitis can form. So we'd have fever, rigors, chills, vomiting, tender abdomen that's going to be hardened, all signs and symptoms that we would need to be looking for and assessing with these two surgeries. Which one of these is the most common?
Is it the Roux-en-Y?
It is. And then which one gives us the greatest amount of weight loss?
The duodenal one.
Yep. The duodenal one, again, is more invasive. It's a bigger procedure. It's going to cut out or rework a greater portion of that GI tract. So it's shorter in a sense. Has a high risk of infection. It is only indicated, remember, for a BMI of greater than 40. So these are our most obese patients that are going to get this. So most surgeries, you need to have a BMI of over 35. But with this one, to even be considered, we want you to be over 40. Well, we don't want you to be, but you know what I mean.
How do you say that one again?
The biliopancreatic diversion with a duodenal switch.
So for the other two, restrictive, what would the BMI have to be?
What they want, so what they do want is a BMI of 40 or a BMI of 35 if they have high blood pressure, diabetes, COPD, other comorbidities. So most people that are obese have these. So a BMI of 35 is that standard. With the duodenal switch, even with the comorbidities, it's a BMI of 40. That's the starting point, if that makes sense. If you're at 35, you're not high enough. All right, so let's talk about post-op care. Remember, post-op care does not vary, okay? Whether you have a toe amputated or part of your lung taken out or part of your stomach taken out, we look for the same things and we do a lot of the same things. Just some assessments might be a little bit different if we're looking at certain incisions somewhere. So post-op, what are things that you would do?
Incentives parameter?
Can't go wrong with that answer, 100%. 10 breaths every hour while awake. Or 10 times. What else would we want them to do?
Ambulation.
Yes, get up and move. Why do we want them ambulating?
Prevent DVT.
That's one of them. That's one of the reasons, absolutely. We want to prevent those clots. What's the other reason we want them moving?
Is it to restart their peristalsis and the
That's
GI?
definitely that. Yep, that's another reason. And a third reason.
Lung expansion.
There we go. We're going to prevent that atelectasis from happening. So it's definitely multifaceted, but we do this for everybody. So we got them up and moving. We got them doing their incentives parameter. What else do we want to do?
Would it be like clear liquids or NPO for the first little bit?
So post-op surgery with our bariatric patients, they're going to be NPO for a day or two, pretty much until bowel sounds can return. They're going to start on clear liquids, and then they're going to work their way up to full liquids, which will include dairy, and then they'll progress over like a week or two. But yes.
So check the incision site.
100%, because we're looking for signs and symptoms of infection, which look like what?
Redness, swelling, oozing.
Heat.
Yep. All those key factoids. So we're ambulating. We are advancing diet as prescribed in this case. Normally it's as tolerated, but because it was a GI surgery, This one's going to take a little bit more time. We're doing RIS. What else do we care about? What are those other interventions?
They can't drink when they're eating, right?
Yeah, so after their surgery, we tell them to drink before or after eating because their contents, they don't have a lot of room in their stomach anymore. Or we don't want them to fill up with liquid. If they are drinking liquid or they have IV fluids,
We want to check their output.
their eyes and their O's. It doesn't matter. We love eyes and O's. We need to know what's going in is coming out. Or if they're getting enough. We can usually tell if they're dehydrated. But if we're watching their input and their outtake or their output, we can see if they're putting themselves at risk or not taking enough or doing too much. So it's not just for restrictive purposes. All right, safety. Let's talk safety. What are some safety interventions you would want in place for somebody that's had bariatric surgery?
Skin integrity.
Okay.
Is this false risk?
They sure are. They had surgery. If you've had any type of mind-altering drug, okay, even if it's prescribed, we're at risk for falls post-op. These, especially with the Roux-en-Y and the pancreatic switch, those are major surgeries, and the sleeve. So they're going to have pain. They're going to have pain medication. So we have to be concerned about falls. And in turn,
level of consciousness.
the respiratory rate, their bowel habits. Yeah, they're going to be on a light diet, but we want to make sure we have good bowel sounds too. So, continuing on with that bariatric diet, what are some things that'll need to be supplemented lifelong with our malabsorptive disorders? So those vitamins, yeah, we're probably going to be doing iron and potassium orally and vitamin B12. Oh, I ripped my shirt. Sorry, I just noticed that thing. I was like, what is that? Let's talk about, more diet. So what are some things that we'd want these patients to eat after bariatric surgery?
I would say like fluids, make sure they're drinking a lot.
Carefully and not with meals, but we do want them to stay hydrated and not to drink our calories. So our Starbucks is probably out. Okay, we want them to eat foods high in nutrients. So that would include things like
Protein.
peanut butter, lean meats, low fat, fish, beans. Let's see what else. Oh, making sure that their serving sizes don't exceed a cup. Okay, we don't want them to eat too much. What is dumping syndrome?
Isn't that where it like leaks from the stomach into the intestine?
So with dumping syndrome, usually when we're eating, there's too much sugar with these gastric patients, and it causes patients to literally dump their bowels. Like it just explodes out of them. So I think dumping syndrome, they're going to be pooping. It has to do with pressure changes, the sugar causing fluid to rush to an area because of the intake, and it expels out of the patient. So there'll be some tachycardia, some abdominal pain, that diarrhea. So the treatment for that, low sugar, more protein. And we can also have our dumping syndrome with our tube feedings, which was a previous exam, but that's when we learned about it the first time. What else do I want to talk about? We talked about the anastomotic leak, talked about the diet. What other things about obesity are you not clear on?
What's the RNYGB?
That's the Roux-en-Y gastric bypass.
Oh, okay.
That's how it's abbreviated. We talked about the sleeve, the band, education. Yeah, okay. What are the causes of obesity?
Lifestyle and like genetics.
Okay.
They can also be psychologic.
So we gave you 5 causes: behavioral, environmental, physiologic, genetic, and the microbiota. Those are the 5 causes of obesity. So
Can you say those one more time? Sorry.
sure, it's on slide number 4, but behavioral, environmental, genetic, physiologic, and the microbiota. And there's a really cute video. It's very good. If you have not watched it in the slides, do that, because it explains the whole microbiota and how it makes somebody susceptible to obesity. And it's really interesting. And she does a way better job of explaining it than I do. And she's got a very soothing voice too. The human biome. All right. Any other questions about obesity? Going once. All right. I want to switch. Do we want to do diabetes or GU?
Diabetes.
All right. So diabetes. All right. What are the 2 kinds of diabetes that we would be testing you on?
Type 1 and type 2.
There you go. What is type 1 diabetes?
Autoimmune dysfunction.
Definitely. Sorry, I'm looking for my notes on this. Okay. So we have an autoimmune disorder. Don't totally know what causes it. It could be an exposure to a viral or genetic. There's a genetic component associated with that. What happens in type 1 diabetes then?
It's the beta cells. I can't remember what it has to do with the beta cells, but I know there's something with the beta cells.
Yep. So we have the destruction of the beta cells. We are no longer producing insulin. So it needs insulin from an external source. So endogenous means your body produces it. It's within us. With type 1 diabetics, they have no endogenous insulin. So we need to give them an external source. What is metabolic syndrome?
Pre-diabetes.
Okay, and what is it characterized by?
Is it abdominal obesity?
That's one of them, yep.
Insulin. re-
Insulin resistance,
Mm.
okay. What other characteristics are there?
If the A1C is above 6%, but below like 6.5.
Yeah, it was like 6 to 6.4. Okay. High blood pressure, high cholesterol, sedentary lifestyle are all risk factors for metabolic syndrome. So these people are well on their way to becoming a type 2 diabetic. This is like a warning sign, like, hello, let's do something. Let's see here. What else about diabetes? Let's see. Oh, it's so extra. I don't know why obesity is on there. All right, so let's talk about, I don't know why that's on there. Type 2 diabetes. Well, what causes type 2 diabetes?
Obesity.
It's one of the risk factors for it.
Isn't it pretty much everything we said before?
Those are some definite causes. So with type 2 diabetes, the cells are no longer responding to the insulin within the body. They're saying, nope, we're done. We typically see type 2 diabetes diagnosed after 30, but we're seeing it more in younger people. Whereas type 1 diabetics, we typically see more of it in the younger population, but it could be diagnosed later in life. Well, let me backtrack. How is diabetes diagnosed?
The A1C.
That is one of them. Yep, one of the tests that we do. And their A1C will be over 6.5 to be considered diabetic. The goal of a diabetic is to be under 7. How else do we diagnose diabetes? I know there's some moms in this group that remember that.
Frequent urinating.
Well, that's a symptom.
The
So-
glucose tolerance test.
There you go, that glucose tolerance test. We drink that sugar, they draw our blood every 15, 30 minutes to see how our body is reacting and bringing it down. Somebody with type 2 diabetes is not going to adjust appropriately, and we're going to still see that continued spike. So they would diagnose it that way. They won't diagnose diabetes with a finger stick. We need more information. So they'll do that glucose tolerance test, they'll do the A1C, and then come to that conclusion.
But isn't the A1C to see how they've been doing for 3 months, or do they also use it for diagnosing?
So for both, because people that get it, if we're newly diagnosing somebody, it gives us a starting point and it's going to be elevated. You know what I mean? Like they're going to have had symptoms for quite some time or not had symptoms, but they've had high blood sugars for a while. So the A1C will kind of give us like a number like, hey, this is where your blood sugars have been averaging. But yes, it is also used as a tool for maintenance to say, yeah, you've had your stuff under control, or no, you haven't. So it does do both. Great question. What are some goals for diabetics?
Weight loss.
Potentially. I say potentially because for them, very often our type 1 diabetics tend to be almost underweight. They can be. They struggle with weight gain. So diabetics as a whole, to prevent complications, we would want what?
Is it to control their insulin and their glucose, blood
Yep.
glucose?
100%. The number one way to prevent complications is to control their blood sugar. So our goals will always be to maintain an appropriate blood glucose, whatever it is for that patient, because they're individualized. And just to not have signs and symptoms of hypoglycemia or hyperglycemia, and that sort of thing. But if they are struggling with weight, then weight will absolutely have something to do with it. Obese patients will hold on to those kinds of things and can make diabetes harder to treat because of all the extra adipose tissue involved. Food. Let's talk about food, meal planning. So we'll determine with our patients, do they need to gain? Do they need to lose? Do they need to maintain? What are some things that we would want them to eat, or groups of foods, or things that we'd want them to avoid? Anything, give me something. Did I lose you?
So limit fats and protein.
Do we want to limit protein?
Well, the slide says 10%, so 10% of the daily value.
And that's for calories. So 10% of those calories should come from protein. So
Okay.
we still want them to have like good lean proteins and things like that. Whole grains, good carbohydrates. So not the Snickers bar, but whole grain bread or something like that. Fresh fruits and vegetables, fiber. What are some things we would need to consider when creating diet choices for our patients?
Any allergies they have?
Absolutely. Let's talk about allergies. Anything else? What big project did we have you do?
Their culture.
Their culture. So is there any type of culture or religious guidelines that we'd want to follow? I could not think of that word, to help with that. If maybe they're Muslim and they don't eat because they fast, like that can have an impact on it. Although I do think they have some religious exemptions. I know Catholics do during Lent, but those are still things that we would want to investigate and help with. Okay. Where's my little, I'm not going to spin the wheel. I'm trying to read like upside down. I'm all like this. Let's talk about juice. The good, the bad, and the ugly about juice. So what's good about juice?
You can raise their blood sugar fast.
Okay, so then what's bad about the juice then?
It might get too high.
Okay. What's the difference between an apple and apple juice?
Oh, are you talking about like the simple sugars and the,
Kind of.
So wouldn't it take longer for the apple to metabolize than the juice?
Yes, so the juice has a high glycemic index, so it causes that spike, which is great if they're feeling low. Let's raise their blood sugar so they don't bottom out, and then we can treat them accordingly. But it's going to eventually come back down pretty quickly too. Whereas an apple will give a good rise in the blood sugar, but not cause it to go too high and not cause them to bottom out. So juice has its place with diabetics, and it's usually when their blood sugar is going low. And remember, when we're dealing with low blood sugar, we don't put anything in their mouth unless they're conscious and talking and can swallow safely. But if we can, then that's what we're going to give them. So we'll give them juice, glucose tablets, graham crackers, whatever they can take, as long as they can do it safely. If they start going all like on you, don't put anything in their mouth. Okay, that's when we're going to look at things like IVs and IV glucose. We didn't talk about this. Signs and symptoms of low and high blood sugar. What does low blood sugar look like?
Diaphoretic.
Okay. Cold and clammy, give some candy. We got to raise that blood sugar. So they'll be pale. There'll be some sweating, irritable, hungry. They're hangry. Think about how you feel when you're hangry. This is what low blood sugar feels like. But they really will have this paleness to them and a stickiness with the sweat. It's kind of, it is very clammy. And then what about high blood sugar?
Excessive thirst.
Okay.
Blurred vision.
Mm-hmm. What are our 3 Ps?
Polyuria, polydipsia, and then I don't remember that.
Polyphagia.
There you go. Those 3 Ps. So these are like our number 1 symptoms that somebody's blood sugar is really high. So if somebody came up into a clinic and was like, yeah, I just want to eat, I just want to drink, I have to go to the bathroom all the time, I'm I'm tired and I have headaches. These are all signs of high blood sugar. And sometimes those 3 Ps are our first step to like, let's check your blood sugar and see if you're diabetic or have high blood sugar, and we can run down that pathway. But you have to know your 3 Ps. So cool and clammy, give them candy. Hot and dry, sugar high. The sugar's high. So if they are low and they're feeling low, like if your patient goes, I don't feel so good. I feel real tired. And you can see the symptoms on them. What's the first thing that you're going to do? What's your priority? They just say they feel funny.
Check their blood sugar.
Please and thank you. Check their blood sugar. We can do all our interventions after that, but we don't give meds until we know what's going on. So let's get that blood sugar. We can have the juice on standby. Go get the glucometer. Go get some juice. Check the sugar first and then do it, because it might be something else that's going on. So absolutely check that sugar first. If they can't swallow and they're starting to lose consciousness, or they're like you're unsure, how do we treat hypoglycemia?
So the IV dextrose.
Yep, we give the IV D50. Super thick. That's what we use when they're losing consciousness or becoming more obtunded. Exercise. What do diabetics need to know about exercise?
Don't exercise if they're stressed.
Okay. What should we have them do before they exercise?
Check their blood sugar.
Okay. And if their blood sugar is over 250,
Don't do it.
don't do it. Yeah. We don't want them to stress an already stressed system. So, yes, exercise helps with reducing blood sugar and reducing insulin. But when you're hyperglycemic, it's stressed on the body. Exercise stresses the body. So it's too much for the body. So let's bring your blood sugar down and we'll go about it another day. Make sure that they're eating a small amount of carbohydrates before they work out. If they're doing moderate to strenuous exercise, so they don't bottom out. Let's talk about insulin. So insulin is one of the therapies for diabetes. What is the only insulin that can be given IV?
Regular.
Regular insulin is the only insulin that can be given IV. Our rapid acting insulin takes effect how quickly after injection? Anybody remember?
Isn't it 15 minutes?
Yeah, it's quick. It is rapid for a reason. So we want to make sure that they have what nearby or next to them?
Like a carbohydrate?
Their food. Yeah, their food. 100%. So with any of those insulins, with rapid or even our regular, we want to make sure that they have food nearby. So the regular insulin has an onset of 30 to 60 minutes. So we have a little bit of time, but it is a good rule of thumb to make sure that your patient eats quickly after getting their insulin. Okay, so we can prevent that drop. Does Lantus, the Glargine, does it have a peak?
No peak.
No peak. It works continuously for 24 hours to lower that blood sugar, kind of maintain it. When we eat, that causes a spike, and that's why they would need like the Lispro, the short acting, to kind of help with those breakthrough spikes. Let's see. Do you guys have questions about insulin? Do you feel good about it? You've probably had it for years now.
What's the fast acting insulin called again?
The rapid or the short acting?
Sorry, the short acting.
The short acting is your regular insulin. That's like your Humulin R or your Novolin R.
Are the questions gonna say the rapid acting, short acting, or is it gonna be the name of the drug?
The name, I would say, is always the generic form of the name. So it would be like Lispro or regular insulin or
Okay.
Glargine or whatever they are. What are some of the subcutaneous sites that we can give insulin in?
Abdomen and back of the arm.
And the thighs. Don't forget the thighs. see here.
Are you guys going to be testing us on like sliding scales with the insulin?
I don't remember any questions about sliding scales, mostly because we can't get the pictures to work. But there may be a verbiage of it.
Okay, because I know like on OB we had like exhibits to like flip through and read, so I didn't know if it was going to be like that. Like we get the patient background and labs, and then we like decide a number based on that.
Oh, I did not do that for this test, so no.
Okay, thanks.
Let's see here. Chronic complications of diabetes. So what are some of the things that we can see if diabetes isn't treated well, long-term effects, long-term complications?
Neuropathy.
100%.
Blindness.
Yeah. Retinopathy.
Like delayed healing.
Yes, so that will go in part of the neuropathy. But what are diabetics really prone to on their feet?
Is it like the ulcers?
Ulcers, yeah, absolutely. So that would be part of one of the things that we need to look for, evaluate for. So chronic conditions, issues with the heart, issues with the kidneys, the eyes, the vasculature, skin, all of those can be affected. DKA versus HHS. So what is DKA?
It's for type 1 diabetes, right?
Most common in type 1 diabetes. Type 2 can happen, but yes, more common in type 1. What happens?
They have the fruity smelling breath.
Okay. Where's my, hold on one second. I'm missing something. That's not okay. I can't find it. All right. So with DKA, we have the breakdown of fat. We have the release of the ketones. So we'd have ketones in the urine. We'd be in an acidotic state, which is where the metabolic acidosis comes from. What else do we have with DKA? The Kussmaul respirations. So it's just deep, rapid breathing, trying to blow off that CO2. And then like nausea, vomiting, abdominal pain. Our labs were going to be acidotic. Again, there'll be ketones in the urine, elevated kidney function, high blood sugar. What causes DKA?
It's like a really high glucose, like over 350.
Yeah, typically with DKA, there's stress or illness or just not taking your insulin anymore. And we have high blood sugars for a long period of time. The body gets doesn't have the insulin to break things down properly. So it starts breaking down those fats. And then we have that whole process and then the ketones being released. So, what about HHS?
Are they still acidotic with this one?
So they're not. Their pH will be normal. But with HHS, what happens is they still have a little bit of insulin that prevents the ketones from happening, from occurring. Whereas in DKA, they don't have that insulin. So that's the big difference. So DKA will have the ketones. HHS will not. With HHS, we're going to have a very, very high blood sugar, like greater than 600. But there'll also be neurological symptoms, like seizures can happen and temporary paralysis. So it's significant. HHS has a higher mortality rate than DKA. With the treatment of both of these, we got to get them insulin. So they're going to be on an insulin drip. We want to give them fluids. We do give them dextrose too to prevent that cerebral edema, because we can't lower everything too quickly. That'll cause swelling. We have to watch their potassium. So remember, insulin will lower potassium levels. So these patients, if they're on insulin drips, are at high risk for hypokalemia. And watching if they're in DKA, their acid base. Remember, ketones, protein, and glucose should never be in the urine. If they are, something is going on. Did I hit all the diabetes topics? Sorry, I'm working on 2 computers right now, trying to do all this metabolic lifestyle. Foot care. Let's talk about foot care. What education would you provide to a patient who is diabetic about foot care? Ooh, that sounds like a test question.
No lotion, no clipping toenails.
Now we want you to file, inspect your feet. What about shoes? What do we want them to know about shoes?
No open toe shoes.
Well, the properly fitting shoes. Definitely. What else? Ooh, oral meds. Who can get oral hypoglycemic medications?
Is it type 2?
Yep, only type 2. Type 1 cannot receive oral hypoglycemics. So our 2 big ones are going to be metformin and glyphoside. Okay, metformin, oldie but a goodie, is great daily dose medication to help with lowering blood sugar. However, puts patients at high risk for developing what? Anybody remember?
Is that the acute kidney disease?
Kidney issues for sure. It can react and cause a lactic acidosis. So we have to be careful with that medication. Has a lot of GI issues. So a lot of times people who start metformin actually lose weight, which is great if we're having weight issues. We don't want it to come in contact with contrast dye. It'll our kidneys. So that's a reason why a lot of times if patients are on it in the hospital, they're not. Glyphoside, no alcohol with that. 30 minutes before eating is ideal dosage time for that med. Major side effect for both of these meds.
Hypoglycemia.
Absolutely. It'll do its job too good and we'll have low blood sugar. Okay. What else about diabetes do you still have questions about, not sure about? anything? Feel good? I'll be around this weekend too if something pops up and you need to shoot me a message. All right. So what about then the GU unit that we did this week is still not clear?
So the GI will be on this exam?
Yes.
Okay.
Did I say GI? I meant GU, the renal system. So the stuff we did this week. Stuff will probably come up this weekend and it's fine. Just shoot me a message and let me know. I know you just had it this week, so it's kind of like fresh in your brain. So it probably makes the most sense out of everything. Anything else I can answer, I can do for you? That's really all I have.
Thank you, Amy.
You're welcome. If stuff
Thank
comes
you.
up- yeah, if stuff comes up, shoot me a message.